Okay, so chapter 3 from our pharmacy technician exam review book. So this book is going to be helpful for reviewing for the PTCB. Also, it will be helpful for reviewing if you decide to take the EXCPT. So this chapter 3, patient safety and quality assurance. So this is regarding the EXCPT exam. So domain 1 is an overview and laws. So A, role, scope of practice, and general duties of the pharmacy technician, assist pharmacist in medication reconciliation, assist pharmacist in medication therapy management, assist patient in selecting compliance aids and devices, dispose of medications based on product specific requirements. Domain 4, medication safety and quality assurance. So follow best practices for quality assurance and medication safety, assist the pharmacist in identifying patient medication adherence issues, use safety strategies to prevent mix-ups between look-alike, sound-alike products, errors with high alert, high-risk medications, and medications with different routes of administration, match patient information to prescription or medication order, follow procedures to assure delivery of the correct prescriptions to patients, take corrective action after detecting potential medication errors or near misses, maintain a clean work environment in the drug dispensing and patient care areas, and perform quality assurance checks of floor stock. Every patient is entitled to rights of safety, the 5 rights of safety. So the right drug, the right dose, the right dosage form, the right route of administration, and the right time of administration. A medication error is a preventable mistake that involves medicine, whether prescription or over the counter. It does not matter whether it is intentional or unintentional. A medication does not need to produce harm to the patient. Often medication errors go undetected. So we have types of errors. So prescribing errors, route of administration wasn't specified, the patient allergies weren't known, incorrect strength of the medication, incomplete medication name, quantity and refills omitted, and additional directions required. So that's like the doctor type error, med order error. Dispensing errors. So mechanical errors during preparation and dispensing of a prescription by either a pharmacy technician or a pharmacist. Judgment, result of a pharmacist making an incorrect decision during the screening of a patient during drug utilization evaluation or while counseling the patient. And then administration errors, oral medications given intravenously, enteral formulas administered parenterally, intravenous medications administered intrathecally, intramuscular preparations administered intravenously, intravenous syringes used to measure doses of oral medication, ear medications being placed in the eye, and irrigation solutions being administered intravenously. And then we have a bunch of different types of error. Again, prescribing error, omission error, wrong time, unauthorized drug error, improper dose, wrong dosage form error, wrong drug preparation error, wrong administration technique error, deteriorated drug error, monitoring error, compliance error, or other medication error. So this is a good chart here, I think. This chart, we have medication error reporting and prevention categories. So circumstances that have potential for causing errors, the type of resulting error is no error. An error occurred, but it did not reach the patient. So that's an error, but no harm. An error reached patient, but did not cause harm. So error, no harm. The error reached patient but did not cause harm, but needed monitoring or intervention to prove no harm resulted. That would still be an error, no harm. An error occurred that may have contributed to or resulted in a temporary harm to patient and patient required intervention. So that is an error with harm. An error occurred that may have contributed to or resulted in temporary harm to patient and resulted in hospitalization. That would be an error harm. An error that occurred that may have contributed to or resulted in temporary or permanent harm to the patient, of course, error harm. And error occurred that may have contributed to or resulted in harm to patient or required hospitalization to sustain life. And that is error harm. And then finally, we have an error an error occurred that may have contributed to or resulted in the patient's death, which is error death. So identified by med marks, we have these causes of prescription errors. So performance deficit, procedure, protocol not followed, transcription inaccurate or omitted, improper documentation, incorrect computer entry, knowledge deficit, communication, lack thereof or incorrect, a written order, incorrect drug distribution center, and handwriting ineligible, or unclear. Of course, we're going to have workplace issues that may contribute to medication errors. If any of you have ever been in a pharmacy, well, obviously not inside of the pharmacy, but you've picked up prescriptions or been around the pharmacy at most places, you know that it can get quite hectic. So some workplace errors are inadequate lighting, an uncomfortable temperature, excessive noise, clutter and crowding, interruptions, inappropriate workload for staff, inefficient workflow. So that is really huge in pharmacy. When working at Walgreens, we had a very strict workflow, which worked out great when we didn't have any call offs or we weren't short staffed or whatever. Then I worked at a pharmacy where I don't know how, but they did not have workflow when I started there. And everyone just kind of did whatever. And it was kind of chaotic. You were, filling a prescription 1 second, next minute you were helping at the, pickup window. So workflow is definitely important. Everybody should have a job. Like one person should be at the drive-thru, one person should be at the pickup counter. Nowadays, the pickup counter and the drop-off counter are usually in the same spot, the same person doing those roles. And then somebody at the fill station, maybe even 2 people at the fill station, depending on the busyness of the pharmacy. Meal breaks not scheduled or taken, lack of staffing, contingency plans to cover illnesses and vacations, which results in short staffing. Floater pharmacist, a substitute staff unfamiliar with practice site. Older technology not replaced. Staff not healthy or working when ill. Staff issues of visual acuity or hearing impairment. So many things can be done to address environmental issues that may contribute to medication errors. So we'll read through some of these solutions. Obviously, clearly identifying workflow patterns that prevent overlap and crossover. So again, workflow. And one thing I forgot to mention when I was talking about it previously is that you should not be stuck at the same place all day long. So even if you start out at the drive-thru, that's your spot. Most pharmacies will switch every 2 hours. At least that's how it went to most places that I've worked. So maintaining workstations that are free of clutter, that is another big one that I love to stress, because sometimes it can get very busy in the pharmacy and you're just grabbing things and filling things and whatever. We should never be leaving medications just sitting on the counter. Some pharmacies require that you send the medication with the prescription that you filled, and that's fine. But you should be putting away those medications as the pharmacist checks them, not every, not like one by one, but once there's a pile there, you should be grabbing it and putting it back. If you work at a pharmacy that does not require that, like Walgreens, for instance, and you'll hear me talk about Walgreens a lot because I worked there for 8 years. So Walgreens, for instance, they have a computerized system that shows them what it should look like. So they don't need the bottle, except for, I think, liquids, they do need the bottle, but so then you should be taking those medications back to the shelf immediately. It is not that difficult. I've worked with many people who like to get a pile started and then take them all back then. It is so much easier to grab it and put it right back. You just got it. You can just go right back and put it back. And then there's not the problem of another person trying to fill the medication. So if there's two people at the fill station, you leave one of the drugs on the counter because you just want to get a pile together before you start putting them back. Well, the other person goes to fill a medication for the patient. They go to the shelf. It's not there. So what are they going to do? They're going to put it into an out of stock or on an order list. When really we have it, it's just sitting on the counter. Ensuring adequate space, storage, and lighting in medication stock and dispensing areas. So having, not clutter in that area as well is really important. Several organizations play an active role in reducing prescription errors. These organizations are the TJC, the Joint Commission, and the FDA, both of which we are going to discuss, and we discussed in chapter 2. In addition, the Institute of Safe Medication Practices provides a variety of tools to be used by both pharmacists and pharmacy technicians to prevent errors. So the ISMP, the organization, provides impartial, timely, and accurate medication safety information. It has developed initiatives built on a non-punitive approach and system-based solutions, which fall into 5 key areas: knowledge, analysis, education, cooperation, and communication. So more of what they do, they collect and analyze reports of medication-related hazardous conditions, near misses, errors, and other adverse drug events. They educate the healthcare community and consumers about safe medication practice, and they conduct research to provide evidence-based safe medication practices. The ISMP provides pharmacy resources that include do not crush list, black box warning list, error prone abbreviations list, community pharmacy medication safety tools and resources, tall man letters, confused drug names, high alert medication list, patient controlled analgesia. Medications that are associated with a high incidence of medication errors, so acetaminophen, Tylenol, albuterol, cefazolin, furosemide, heparin, insulin, morphine, potassium chloride, vancomycin, and warfarin. The ISMP has identified high alert medications that may cause patients specific harm if they're used in error. So we have classes and categories of high alert medications in acute care facilities. So adrenergic agonists that are intravenous, so epinephrine, norepinephrine. Adrenergic antagonists, IV, like propranolol, metoprolol, and labetalol. Anesthetic agents, general inhaled and IV, like propofol or ketamine. Antiarrhythmics IVs, like lidocaine and amiodarone. And antithrombotic agents, including anticoagulants, factor XA inhibitors, direct thrombin inhibitors. So like dabigatran, agritron, thrombolytics like alteplase, rutaplase, glycoprotein 2B, 3A inhibitors. Cardioplegic solutions, chemotherapeutic agents, both parenteral and oral, dextrose, hypertonic 20% or greater, dialysis solutions, epidural or intrathecal medications, hypoglycemics, inotropic agents, insulin, subcutaneous and IV, liposomal forms of drugs, moderate sedation agents, oral for children, narcotics and opioids, IV, transdermal, and oral, neuromuscular blocking agents, parenteral nutrition agents, radio contrast agents, IV, sterile water for injection, inhalation, and irrigation, excluding pour bottles or containers of 100 ml or more, and sodium chloride for injection, hypertonic, greater than 0.9% concentration. And then we have specific high alert medications in acute care facilities. So magnesium sulfate injection, methotrexate oral for non-oncologic use, so not for cancer, opium tincture, oxytocin, promethazine, and many more. Classes and categories of high alert medications in community ambulatory care pharmacies. So antiretroviral agents, so HIV and AIDS medications, oral chemotherapeutic agents, excluding hormonal agents, hypoglycemic agents, immunosuppressants, insulin, opioids, pediatric liquid medications that require measurement, and pregnancy category X drugs. Then we have specific high alert medications in community ambulatory care pharmacies or facilities. So you can see here the tall man lettering that's bolded. So we have carbamazepine, chloral hydrate liquid, heparin, metformin, methotrexate, midazolam, propylene and warfarin. And then we have classes and categories of high alert medications in long-term care facilities, anticoagulants, both parenteral and oral, chemotherapeutic agents, parenteral and oral, hypoglycemics, oral, insulins, all formulations and strengths, parenteral nutrition preparations, opioids like parenteral, transdermal, and oral. Then we have look-alike, sound-alike medications. There have been many drug names that either look alike or sound alike that have resulted in medication errors and have been identified by reporting them through the ISMP MERP. So here's some examples of look-alike, sound-alike drugs. So you can see like Advair, Advocor, Celebrex, Cerebrex. So there's quite a few. Error prevention strategies. So the Joint Commission's goal is to improve patient safety, improve the accuracy of patient identification, improve the effectiveness of communication among caregivers, improve the safety of using high alert medications, and improve the safety of using infusion pumps. Now here is the Joint Commission's do not use list. So these are all the SIG codes and stuff that we should not be using. You should not abbreviate U for unit. You should write unit. You should not abbreviate IU and put international unit because it can be mistaken for IV or the number 10. Trailing zeros. You should always be writing 0.x. So 0.5, not 0.5. And then we have the error prone abbreviation list. So you can see kind of that, like HS for half strength is mistaken as bedtime. And a few other ones like SC is sometimes mistaken as sublingual. Then we have the Food and Drug Administration and Institute of Safe Medication Practice list of drug names with tall man letters. So these are the drug names with tall man letters like bupropion, glyburide, hydralazine, and what they're confused with. And here is some additional drug names with recommended tall man letters. So alprazolam, sometimes confused with lorazepam. Metformin is sometimes confused for metronidazole. Tramadol is sometimes confused for trazodone. Then we have a do not crush list. So we should not crush slow release dosage forms, extended release dosage forms, enteric coated dosage forms, and sublingual dosage forms, and many more. Read through those. And here's examples of medications that should not be crushed. So Accutane, Actonol, Adalat CC, Allegra D, Ambien CR, Augment Nexar. So you're seeing a lot of these are the controlled release or the extended release. Those should never be broken. Avodart, Calin SR, Cardizem, CDLAXL, Cymbalta, Depakote, Detrol LA. There's a lot of them, but you can see what I mean. So medication therapy management, which we abbreviate as MTM, it's a medication management therapy service that pharmacies offer. So medication therapy review, a systemic process of collecting patient-specific information, reviewing the patient's medication and medical history, and identifying possible medication-related problems with possible plans to resolve them. The MTR is the first step in an MTM service. Personal management record, a comprehensive medication record of the patient's prescriptions and non-prescription medications, as well as herbal products and other dietary supplements. The PMR should be included in every MTM service. Medication-related action plan, a patient-centered documentation designed to assist the patient in managing and tracking their progress towards the actions identified in an MTR. Intervention and or referral, the pharmacist provides consultative services and intervenes to address medication-related problems. If necessary, they refer the patient to the physician and or other healthcare providers. Documentation and follow-up must be documented in a uniform manner. A patient is scheduled for a follow-up based on their individual needs or when the patient is transitioned from one patient care setting to another. So roles of the pharmacy technician in MTM management. So they assist with analyzing and optimizing the workflow in the pharmacy, identify processes and procedures that may be modified or eliminated to save time, promote the availability of MTM services to patients, and assist in the scheduling. In situations when pharmacy technicians can promote medication therapy management services. So some patients that were recently discharged for hospitalization, experiencing complications of a chronic disease, transitioning to an assisted living group home or skilled nursing facility. Next, we have medication reconciliation. This is a process of comparing a patient's medication orders with all of the medications that the patient had been taking prior to admission to the hospital. Medication reconciliation is performed to avoid medication errors such as omissions, duplications, dosing errors, or drug-drug interactions. Medication reconciliation is the result of a Joint Commission National Patient Safety Goal. So here is an example of a medication reconciliation form. So the steps: develop a list of current medications, develop a list of medications to be ordered and prescribed by the admitting physician, compare the medications on the two lists, make clinical decisions based on the comparison, and communicate the new list to appropriate caregivers and the patient. So I actually did do this job for a couple of years in the hospital emergency care center setting. So it's kind of an interesting job. A lot to learn. Medication errors can occur as a result of the processes used involving the pharmacy's inventory. So picking the next drug on the shelf, medication stacked incorrectly, a lack of shelf dividers used on crowded shelves, crowded will call pickup area, recalled and discontinued drugs not segregated from active stock, reconstitution and compounding ingredients stored in close proximity. And then these errors can be reduced by implementing a stack program that completely separates ophthalmic and otic products that have been reported as being confused for one another, and a lot more that you can do. E-prescribing is the prescriber's ability to electronically send an accurate, error-free, and understandable prescription directly to a pharmacy from the point of care. It is an important element in improving the quality of patient care. So some benefits of e-prescribing: it prevents prescription drug errors, which is a big one. So much easier than the patient having to bring in that paper script, and it actually saves the patient a trip, because most patients would drop off a paper prescription and come back later and get it. Provides automated clinical decision support, speeds up the medication reconciliation process, supplies instant notification of allergies, drug interactions, duplicate therapies, and other clinical alerts, tracks patient fulfillment of prescriptions, reduces the number of lost prescriptions, enables physicians to electronically prescribe controlled substances in a single workflow, and it makes it easier to verify insurance coverage. Barcode usage helps prevent errors. It reduces dispensing and medication errors, includes the product's NDC number. It's used in both community and hospital pharmacies. Some advantages of barcodes: it creates a better relationship between the patient and caregiver. Before a nurse administrates medication in a hospital, he or she is able to scan the barcode on the drug against the patient's wristband. So there's no reason that the patient would be given another patient's medication based on that. Some disadvantages would be not all medications are barcoded to the dose. Not every drug is barcoded, and there are many unique dosage forms, and the cost of implementing barcoding is high. So pharmacist intervention on drug utilization evaluation, which was formerly known as a drug utilization review. So drug utilization evaluation is mandated by the Omnibus Budget Reconciliation Act of 1990, over 90. Every patient who has filled a prescription in a particular pharmacy has a patient profile. During the prescription filling process, a new prescription is checked against all of the medication in the patient's profile to determine if a possible interaction may occur, the drug is contraindicated, or the patient may be allergic to the medication. If the computer system detects a possible interaction, a warning will appear on the screen to alert the pharmacist or pharmacy technician. The pharmacy technician must stop the filling process and alert the pharmacist. The pharmacist will examine the patient's profile and make a decision as to whether to continue with the filling process. Some factors that may affect the pharmacist's decision include the date the prescription was filled, whether the medication is still being taken by the patient, whether the physician was aware of the other medication being prescribed, the severity of the interaction, such as filling a prescription for amoxicillin when the patient has taken an oral contraceptive. So there are types of DUEs. So prospective evaluation of a patient's therapy before medication is dispensed. It allows the pharmacist to identify and resolve issues before the patient actually receives the medication. Concurrent ongoing monitoring of drug therapy during the course of treatment. It allows the patient's therapy to be altered. Retrospective review of therapy after the patient has received the medication. Patient medical charts or computerized records are screened to determine whether the drug met approved criteria and aids prescribers in improving care for their patients, individually and within groups of patients, such as those with diabetes, asthma, or high blood pressure. So the Beers criteria for potentially inappropriate medication use in older adults. The American Geriatric Society Beers criteria for potentially appropriate medication use in older adults is an explicit list of PIMs best avoided in older adults in general, and to those with certain diseases or syndromes prescribed at reduced dosage or with caution or carefully monitored. Beers criteria PIMs have been found to be associated with poor health outcomes, including confusion, falls, and mortality. Avoiding PIMs in older adults is one strategy to decrease the risk of adverse events. The AGS Beers criteria identify PIMs based on the following criteria. So the American Geriatric Society Beers criteria for potential inappropriate medication use in older adults identified: first generation antihistamines like diphenhydramine, which is Benadryl, hydroxyzine, anti-Parkinson agents, antithrombotics, anti-infectives, peripheral alpha-1 blockers, central alpha blockers, tricyclic antidepressants, antipsychotics, first and second generation, barbiturates, benzodiazepines, hypnotics, insulin, long-acting sulfonylureas, proton pump inhibitors, non-steroidal anti-inflammatory drugs, skeletal muscle relaxants. And the American Geriatric Society bears criteria for potentially inappropriate medication use in older adults due to drug disease or drug syndrome interactions that may exuberate the disease or syndrome identified. The American Geriatric Society bears criteria for potentially inappropriate medications, drug classifications to be used with caution in older adults identified. So dabigatran, antipsychotics, diuretics, carbamazepine, SNRIs, SSRIs, TCAs, and vasodilators that should be avoided in older adults. So this chart lists some of the different classes of medications and the condition they can exuberate. So NSAIDs and aspirin, they can exuberate gastric or duodenal ulcers and all of the other ones. The pharmacy technician may ask patients if they have any questions about their medication, but it is the pharmacist's responsibility, not a pharmacy technician's, to counsel a patient. The following information can be given to either the patient or the patient's representative. This information is not considered to be counseling. The name of the medication, dosage form, dosage, route of administration. However, providing the information below is considered counseling because these decisions should be made by the pharmacist. So the duration of therapy, action to be taken if the dose is missed, common or severe side effects, interactions and contraindications of the medication to include food, self-monitoring of medication, proper storage of medication, and special directions for use. Drug adherence is defined as the extent to which a person takes medication as prescribed and is directed by their healthcare providers. When patients underuse or overuse their medication, it leads to non-adherence. Non-adherence may be caused by either patient or provider barriers. So some examples of patient barriers, which if you work in medication reconciliation, you will see a lot more of and be able to pay attention to it more, as in the retail setting, you really probably don't pay attention that much as technicians, but to specific patients. So medication cost, huge one, side effects of treatment, personal beliefs and perceptions, ignorance, forgetfulness, lack of resources, duration, frequency, and complexity of therapy, improper administration technique, and severity of disease. Examples of provider barriers: patient physician miscommunication, lack of awareness among clinicians about basic adherence management principles, apathetic physician attitudes. And pharmacy technicians can assist in patient adherence. They can collect demographic information, gather medication histories, administer adherence assessments to patients, organize patient med lists, make initial appointment scheduling and reminder calls, collect patient data to identify those patients not adhering to their medication, promoting medication adherence programs by distributing brochures, respond to calls from physician offices and patients regarding any queries of the program, communicate with physicians' offices and faxing requested documents, and track patient improvement with adherence. Any injury caused by a drug and any harm associated with the use of a drug may result in an adverse drug event. If a patient informs the pharmacy technician of an adverse drug event he or she experienced, the pharmacist should be informed immediately. The pharmacist will collect information regarding the adverse drug event, notify the prescriber to determine if the current therapy should be continued, and if necessary, file an FDA adverse event reporting system report to the FDA. Drug interaction. So while performing a concurrent drug utilization evaluation, a pharmacy technician will be made aware of any drug-drug interactions that are present. The pharmacy technician should inform the pharmacist of these drug interactions. Therapeutic interchange between AB rated medications, brand generic, is performed to contain drug costs. It may be done in a pharmacy without the physician's approval. However, if a physician indicates on the prescription that substitution is not permitted by writing dispense as written, brand name necessary, medically necessary, or any other wording that has been approved by the State Board of Pharmacy, the generic may not be dispensed. Therapeutic substitution between products of the same drug classification, even though they are not therapeutically equivalent, may be permitted if state pharmacy regulations allow for it. Often therapeutic interchange occurs in hospitals where formularies automatically permit therapeutic substitution without the physician's approval. In retail pharmacy, an insurance company may require therapeutic substitution. When this situation arises, the pharmacist must contact the prescriber and obtain permission to make that substitution. Only a pharmacist can recommend over-the-counter medications to patients after evaluating their symptoms and other medications they may be taking. When a pharmacist recommends an OTC med to a patient, he or she is making professional judgment that is in the realm of pharmacist practice. We, as pharmacy technicians, are not permitted to make professional judgments under any circumstance. Patients should ask the pharmacist what to do if they forget a dose. Situations vary depending on the medication and frequency of dosing. Providing this information is part of counseling and can only be done by a pharmacist. Double counting narcotics. It's a good practice to double count narcotic prescriptions before they are dispensed and to have the count verified by the pharmacist or another pharmacy technician. So most places do require you to double count narcotics. If they don't, I highly recommend that you do. Some pharmacists will double check and count as well, and not necessarily because they think that you didn't put the right amount or they think you're doing something shady. I mean, there's been times when I filled a prescription and a pharmacist looked at it and was like, there is not 90 in here. And I was like, oh, I only put 30. So stuff like that. When you're just busy and things are happening. So reporting procedures, medical error documentation, incident reports. So incident reports are used to report accidents and events involving employees, individuals, visitor injury, property damage, or occupational illness. It should be filled out by the individual observing the incident or initially being informed of the incident and filed with the supervisor on duty. Incident reports contain the following information: information about the person involved in the incident, information about the incident, and individual or supervisor information. And we should encourage pharmacies to report errors and find causes for the error without fear of punishment. Tracking med errors. So medication errors are tracked through multiple organizations: the FDA, the Center for Disease Control and Prevention, the CDC, the U.S. Pharmacopoeia, USP, ISMP, and the National Coordinating Council for Medication Error Reporting and Prevention. The FDA established MedWatch as a voluntary program to report adverse events or centennial events that are observed or suspected for human medical products, including serious drug effects, product use errors, product quality problems, and therapeutic failures for prescriptions or over-the-counter medicines, biologics, blood and plasma derivatives, allergenic, human cells, tissues, and cellular and tissue-based products, medical devices, combination products, special nutritional products like dietary supplements, infant formulas, and medical foods, cosmetics, foods and drugs, and utilizes an online voluntary reporting form to report these incidents. MedWatch is not used to report vaccine incidents, and MedWatch provides safety alerts for human medical products that include drugs, biologics, medical devices, special nutrition, and cosmetics. The FDA established the FDA Adverse Event Reporting System, which is a database that contains information on adverse event and medication errors reported to the FDA. The database is designed to support the FDA's post-marketing safety surveillance program for drug and therapeutic biologic products. Reporting of adverse events and medication errors by healthcare professionals and consumers is voluntary in the United States. FDA receives some adverse event and medication errors reports directly from healthcare professionals and consumers. Healthcare professionals and consumers may opt to report adverse events and or medication errors to the product's manufacturers. If a manufacturer receives an adverse event report, they are required to send the report to the FDA as specified by regulations, and the reports received directly and the reports from manufacturers are entered into the FAERS. It's important to report adverse drug events, maybe not so much as if you take something and you have a headache and you notice that every time you take it, it gives you a headache or gives you a stomach ache. But if something really bad happens to you, you should definitely report it to somebody, because we want the drug manufacturers to know that that is happening to people that are taking it. And if it's happening to you, it might be happening to somebody else. And that's how we find out that drugs are the different side effects, if you will. So vaccine adverse event reporting, the FDA co-sponsors the vaccine adverse event reporting system with the CDC. Similar to the FAERS, VAERS is a post-marketing safety surveillance program collecting information about adverse events like possible side effects that occur after the administration of vaccines licensed for use in the United States. It collects and analyzes data from adverse events after vaccination. Information collected is used to identify any new safety concerns that otherwise may not come to light before licensing. Reports may be generated by healthcare providers, vaccine manufacturers, vaccine recipients, and state immunization programs. Healthcare providers are required to report the following: any event listed by the vaccine manufacturer as a contraindication to subsequent doses of the vaccine, any event listed in the reportable events table that occurs within the specified time period after vaccination. The ISMP established a voluntary practitioner and consumer reporting program to learn about medication errors, understand their causes, and share lessons learned with the healthcare community. The ISMP operates 3 national reporting programs: the National Medication Errors Reporting Program, the National Vaccine Errors Reporting Program, and the National Consumer Medication Errors Reporting Program, and all information collected is submitted anonymously. So both regulatory agents and drug manufacturers are notified of desired changes in products when the patient's safety is of concern. Medication and vaccine errors, preventable adverse drug reaction, close calls, and hazardous conditions may be reported. Types of errors that can be reported include misuse of medical equipment, calculation of preparation errors, wrong route of administration errors, confusion over look-alike, sound-alike drugs or similar packaging, wrong patient errors, wrong drug, wrong strength, or wrong dose errors, errors in prescribing, transcribing, dispensing, administering, and monitoring of medications and vaccines. So the MERP information guidelines, information that is obtained through MERP is used to report the medication error, understand the medication error, provide additional knowledge of the problem, evaluate data that has been collected, and develop educational tools. The NCC MERP communicates information to consumers, employers, and healthcare providers, and provides a voluntary reporting program. MedMarks is an internet accessible anonymous medication error reporting program designed for hospitals and health systems to systemically collect, analyze, and report medication errors. It is overseen by the USP, the United States Pharmacopoeia. National Coordinating Council for Medication Error Reporting and Prevention is an independent body composed of 27 national organizations. It encourages medication error reporting, fosters medication error understanding, and works toward preventing future medication errors. A near miss is a medication error that does not reach the patient. Typically, near misses are identified during the final pharmacist check of a prescription Near misses should be documented on a pharmacy near miss error log, which should contain information that includes the context of where and how these near misses occurred. Root cause analysis. So many state boards of pharmacy require a community pharmacy to have a continuous quality improvement program in place. Many of the state regulations require a root cause analysis in the case of a centennial event. The Joint Commission defines a centennial event as an unexpected occurrence involving death or serious physical or psychological injury or risk thereof, and recommends completing RCA for all centennial events that happen in healthcare organizations they accredit. RCA is a systemic process to identify the causal factors that contributed to the occurrence of that centennial event. RCA focuses primarily on systems and processes, not individual performances. Finding and identifying root causes during an investigation adds considerable value by pointing out significant underlying and fundamental systemic conditions that increase the risk of adverse event. RCA identifies system and process changes needed to improve performance and reduce the risk of a similar event or close call from reoccurring. RCA is designed to describe what happened during a particular occurrence, determine how it happened, understand why it happened, recommend actions to prevent it from happening again. When assessing the root cause of the incident, various trigger questions are used and include human factors and communication, human factors and training, human factors, fatigue and scheduling, information, equipment, rules, policies, and procedures. Medication error reporting and prevention recommendations. Develop written policies and procedures for persons who administer medication. Provide training to personnel who are responsible for medication management. Ensure that controlled medications are stored properly to prevent theft and diversion. Encourage personnel to report medication errors to appropriate drug error reporting programs. And when a medication error occurs, evaluate possible causes to improve the facility system for drug management and to prevent future orders. Medication error reporting and prevention recommendations for verbal orders. Initiate institutional policies that describe limitations or prohibitations on use of verbal orders. Provide a mechanism to ensure validity and authenticity of the prescriber. List the elements required for inclusion in a complete verbal order. Describe situations in which verbal orders may be used. List and define the individuals who may send and receive verbal orders. So hygiene and cleaning standards, infection control, hospital pharmacy staff will be required to be tested for tuberculosis on a yearly basis. All pharmacy staff should receive an influenza immunization every year. Proper hand washing techniques include washing the hands and arms with hot water and betadine, scrubbing both the top and bottom of the hands, scrubbing between the fingers and up to the elbow, and rinsing the arms and hands thoroughly. Microorganisms can be introduced into the laminar flow hood by jewelry, cosmetics, coughing, or sneezing. If a mask is not worn, or loose facial hair. The Joint Commission states that the pharmacy infection control policies and procedures must address the following. So let's go through some of these. So hand washing technique and personal hygiene requirements, microbial monitoring of laminar flow hoods, preparation of sterile parenteral nutrition products, proper use of laminar flow hoods, and use of single dose and multi-dose containers. Pharmacy personnel competencies and evaluation. USP 795 requires pharmacy personnel to be able to read and interpret safety data sheets, be familiar with each of the procedures related to compounding to include those involving the facility, equipment personnel, actual compounding, evaluation, packaging, storing, and dispensing, be fully trained in the storage, handling, and disposal of hazardous drugs prior to compounding such products. USP 797 requires all pharmacy personnel to be competent in performing the following: proper hand hygiene technique, proper glove and garbing technique, including successful glove fingertip tests, proper aseptic technique, including successful media fill tests, proper cleaning and disinfecting procedures, including successful surface sampling tests, and USP 797 requires specific assessment to be completed on the following: media fill testing and glove fingerprint testing. OSHA requires general training on chemical label elements in SDS format. Dress code. So institutional dress codes require that pharmacy technicians wear a white laboratory jacket. That is not necessarily true. Wherever you work, you could be wearing scrubs, you could have a lab jacket, you could be business professional. So you'll find out from where you work. And if we're talking about the hospital and like the clean room type stuff, you'll just be garbed up. So you wouldn't be wearing a white lab jacket. Your hair should be pulled back. Fingernails should be kept clean and short. Nail polish should be non-acrylic to prevent fungal infections from occurring. Jewelry should not be worn during aseptic technique because of the possibility of contamination. Makeup should not be worn because of the particulate nature of the substance. Clean, particulate-free clothing should be worn. Hand hygiene using gloves does not eliminate the need for hand washing. Liquid soap is preferred over bar soap. Hands should be washed after using the restroom, before and after contact with a patient, before donning gloves for working in the laminar flow hood, before eating, and when they are visibly soiled or dirty. Alcohol preparations are effective if hands are not visibly dirty and soap and water are not available. Alcohol-based antiseptics should be applied to all surfaces of the hands and fingers, which then should be allowed to dry. And persons involved in the preparation of sterile products should scrub their hands with an appropriate antibacterial agent for predetermined time and dry them with paper towels. This procedure should be repeated if possible contamination occurs. Personal protective equipment is used to place a barrier between the employee and specific substances. We call it PPE. They include sterile gloves, masks, goggles, face shields, gowns, lab coats, shoe coverings, and head coverings. A face shield should be worn when splashes to the eyes, nose, or mouth may occur. Gloves should be changed hourly or immediately after contamination. Removal of gloves should be performed in such a way as to avoid direct skin contact with the outside of the glove. Employees must know the proper sequence for donning and removing gowns, gloves, protective glasses or goggles, shoe covers, hair covers, and face shields before compounding sterile preparations. The employer must provide hypoallergenic gloves and liners to employees who are allergic to latex. Environmental monitoring documentation. USP 797 requires environmental monitoring, temperature monitoring, non-viable and viable airborne particle testing program monitoring, and surface disinfection, sampling, and assessment to be documented. Environmental documentation is required with new equipment every 6 months for recertification of equipment. Temperaturing monitoring must be performed and documented at least once a day. Pressure differential must be performed and documented at least once a day. Non-viable particle sampling must be performed and documented every 6 months. Electronic device sampling of viable particles must be performed and documented every 6 months. Surface disinfection, sampling, and assessment must be performed and documented every 6 months. So for equipment, pharmacy weights need to be calibrated once a year. Let's go through a couple of these. Counting trays should be cleaned with alcohol after every use to prevent cross-contamination from occurring, which might result in an allergic reaction in another patient. A separate counting tray should be used for chemotherapeutic agents only. Automated compounding and repackaging equipment must be calibrated before each use. So make sure you read through those. And then we have the minimum frequency of disinfecting compounding areas. So here we have the site and the minimum frequency. The ISO class 5 is just whatever kind of laminar flow hood biological safety cabinet that you have. And tips to prevent errors. Many medication errors occur because of system errors. Accuracy is important during the entire prescription filling process. Ensuring the patient information is accurate and up to date can help reduce allergic drug reactions and drug-drug interactions. Always question ineligible handwriting. Make sure prescriptions and orders include the correctly spelled drug name, strength, appropriate dosing, quantity or duration of therapy, dosage form, and route. Missing information should be obtained from the prescriber. Question ambiguous orders. Question the prescription order that uses abbreviations you're not familiar with or that are uncommon. Use the metric system. A leading zero should always be present in decimal values less than 1. Know the common look-alike and sound-alike drugs. The prescription label should be compared with the original prescription to ensure the information entered is correct. The use of automated dispensing equipment will reduce med errors. Pharmacies are required to maintain a professional library relevant to the practice of pharmacy and keep dangerous or high alert medications in a separate storage area.